Okay. Good afternoon and
Hello.
good morning. Hello.
Yes, this is Emmanuel.
Hi, Emmanuel.
How are you, Toby?
I'm good, and how are you?
I'm fine. I
Good,
just want
thank
to check with Frank that he has everybody online before we
Okay.
start.
Okay. I'll wait to hear from you then, Emmanuel.
Yes, I just wanted to ask Frank if everybody is on.
Yes, we have 31 participants so far.
Can I just do a brief introduction of Toby, then we start?
Thank you, Emmanuel.
Yes, you're very welcome. Good afternoon, ladies and gentlemen. This is Dr. Emmanuel Ririka from the African Palliative Care Association. I take this opportunity to welcome Toby to make a presentation on how African communities are taking on the COVID pandemic and updating us from a truly continental and African perspective. And we hope to learn a lot from this because most of the palliative care providers that we work with are basically linked to the communities. That's why we value this presentation. Toby, thank you very much for accepting to take a lead on this. And just for the viewers and listeners, Toby is also one of the board members at the African Palliative Care Association. You are welcome, Toby.
Thank you so much, Dr. Emmanuel, for the introduction. As Dr. Emmanuel has indicated, my name is Thobekile Finga. I'm currently employed by Oram Institute, and I'm also the member of the African Palliative Care Association. And I'm quite passionate about the topic, particularly that involves community. And my career really started at Naledi Hospice in Bloemfontein in South Africa, the year 2000. So this is something that is quite close to my heart. We can move to the next slide, Frank. So just to quickly look at what is the data telling us currently. The African region continues to register a steady increase in confirmed cases in 45 countries. In total, the African region reported 19,497 confirmed cases and 812 fatalities, illustrating more than 1,405 new cases over 24 hours, which is extremely alarming. South Africa accounts for the highest number of cases, followed by Egypt and Algeria. However, Algeria and Egypt have the highest number of deaths. So within the SADC region, what has been reported is 5,714 confirmed cases and 140 fatalities, which is an increase of 347 cases over 24 hours. South Africa has 74% of the total cases and 56% of the total deaths. This slide was presented recently by the Minister of Health in South Africa, and I've just highlighted the data is as at the 24th of April. We can move to the next slide. So this is quite a difficult question. So the presentation is about asking ourselves that, are African communities in Africa taking COVID seriously? And what I wanted us to start thinking about is that what could inhibit Africans in taking this deadly pandemic seriously? I think human behavior will determine how quickly COVID-19 spreads or is going to stop spreading. I think as healthcare professionals, the starting point of any behavior change, and we've got good lessons learned from HIV and TB, is that we need to have a clearly and specifically stated strategy that will enable the required behavior. The COVID model somehow help us understand how we can influence this behavior. There needs to be capability in terms of knowledge that is required for any human being to make an action, even in situations where their own life is being threatened. What is the opportunity that exists? If you look at the social norms, or if you look at the resources that exist within the communities that we possibly are referring to, are those resources available, and what is the motivation? So this model really offers us an opportunity to say, do Africans have capability, opportunity, and motivation to treat the deadly COVID-19 pandemic seriously and adjust our daily lives so that we can be able to prevent the behavior. The next slide. So what I started thinking about is that, is it a question of yes, we are taking this seriously, or is it a question of no, we are not taking this seriously? And somehow I find that I've got multiple answers just looking at the context and situations in which are happening currently in Africa. Yes, I think there is some part of the community that is taking this seriously. The only thing that's really impeding this is that people are failing to adjust their behavior simply because of how Africans are generally socialized. We are social beings that are used to being together, and sometimes it's not like it is the choice for us to being together. You do find households of people living with multitudes of people, even in the same household or even in the same yard. Unfortunately, COVID-19 is challenging this norm. So to a certain degree, is challenging who we are for the rest of what we know, because we've lived all our lives being social beings, and suddenly the pandemic is requiring us to get out of that norm and start thinking about isolation. And COVID-19 is isolating societies and nations from each other, and it's not something that people are used to. The other question that I want us to think about or to ponder about, is it perhaps too early to judge at this point whether we are taking this seriously or not? But I think as healthcare professionals, our aim is saving lives, and therefore we can never say it is too early to judge. But I think the judgment comes with how long does behavior change? If you look at how long HIV has been with us, and how up until this point we're still struggling to change behavior around prevention, COVID is almost going to be no different to a certain degree. Some of the communities are in a stage of denial. Some are finding ways of coping with COVID, and that becomes generally challenging. So ordinary men and women in the village initially could not identify with COVID messages because it talks about social distancing, it talks about quarantine, it talks about self-isolation. So how do I self-isolate when literally my living conditions do not allow me to self-isolate? So I think as we try and find strategies, we're going to have to find ways and means of communicating properly, because like we indicated in the previous slide, unless we are clear in how we are communicating with our communities, it's going to be very difficult for them to change behavior, and it needs to be relevant to their context. Some people still perceive themselves to be at low risk of contracting COVID-19. And this is also related to the initial messaging, because it was talking about the older population that's vulnerable, and somehow other people felt that they do not fall within that category. Therefore, that's not what is happening. In South Africa, it was termed a disease of travelers. Therefore, I'm immune because I'm not traveling. But unfortunately, if you look at the manner in which communities are densed in lower middle income, it's going to be where the transmission of COVID will be of challenge. And I thought about, no, perhaps the community is not taking this seriously, because in countries where lockdown measures have been instituted, what you are picking up is that very few communities are locking down voluntarily. You still see people in other communities, particularly those that are not affluent, where it looks like it's a public holiday. To them, everything is happening as if nothing has happened. And in order to institute some kind of measure of lockdown, military had to be deployed to be able to regulate this. And there are dangers in this. There are funding implications in the sense that now unplanned military deployment is now meant to be in communities, and this is not something that was appropriately funded for prior, and this is coming from the local national resources. Also, there is danger in relying on the use of military in a weak and fragile state, where democracy may regress. And we're also seeing a lot of clashes between communities and uninformed military personnel. We can move to the next one. So what I wanted us to think about, is it perhaps necessary, instead of saying, are communities in Africa taking COVID necessary, should we rather rephrase that question and say, why are the African communities not taking the deadly pandemic seriously and adjusting their behavior accordingly? So the challenge here is, we know that across Africa, there's a notion of Ubuntu and communalism. It is of great importance in an African educational discourse. And this is really going to affect how we change the behavior, because it's a learned behavior over time. Some values are universal and are recognizable across cultures. But we are also acknowledging that this is not to say that there is homogeneities of culture amongst various African nationalities. But what are we saying? What we are saying is, we need to build a better communality in the communities during the COVID-19 pandemic. And we need to do that understanding the conditions of our people and the previous legacies that exist. Next slide. So what did we see as soon as COVID-19 hit us and the lockdown measures were instituted across the country? The reality suddenly dawned in Africa that there's balance of socio and economic realities, and that affects how we deal with any type of diseases. Because one, we did not have proper infrastructure, we did not have adequate water and sanitation. And what are we asking people as part of the COVID messages? Wash your hands frequently, as much as you can. The other picture is just showing how panic buying just went out, but this was just applicable to those that could afford to do so at the time. But at the same time, people started collecting from hospital bins the mask and started reselling them. And this is the biggest challenge that's going to impact to infection control. And we know and understand that in order to contain COVID in any way, form or measure, infection control measures, it is going to be pivotal. And if this is what is happening in our community, how are we going to deal with it? So what it is that we need to do, we honestly, as healthcare providers, needs to engage our communities meaningfully, understanding their context. I'll keep referencing HIV and TB as part of the lessons that we've learned. We've learned that with HIV and with TB, we're still struggling with people not completing their treatment, with people not adhering to their treatment. Is COVID going to be different? Are we suddenly going to expect communities to suddenly be advocate of their own hands, of their own health, when this is not something that they've been doing? Next slide. This slide depicts the reality of what Africa is faced with just across the region. Like I indicated, socio-economic conditions, safe, clean water. We are unable to do that because we do not have water. Look at how dense the population is. One shack after another, the number of people that are living in this household. So I think the question has to be, where do you draw the line and the balance between what is normal, between what is the context in which we find ourselves in, and how do we as healthcare professionals and any other people that are involved, including municipalities, in trying to address the messaging that is relevant to the context that is depicted in this picture. Next slide. Immediately after the lockdown was instituted in South Africa, per the other previous slide, what had happened is that those that could have afford, that are not living on hand to mouth, could quickly go store up toilet paper, stock up on sanitizer, anything that they deemed at that point was essential. But then what happened to an ordinary person in the community? They needed to wait up until the end of the month for them to receive their salaries. And then what also happened to the older population that we said it is a risk of contracting COVID, guess what? They came as well at the end of the month, one to come and collect their social grant, but at the same time also had to queue for the social, for the essential needs that they required. When people are fetching water in central areas because there is no water, they're faced with the same challenges. So we have to look at different communities are going to require different strategies in terms of how we deal with COVID-19. It's not going to be a one-size-fits-all, even in the same country. One region or one district may be different to the other. So I think hospices have a unique opportunity where they are embedded in the community, they live within the community, they understand the context, they understand the environment. When they come up with interventions or advise government in different structures, because COVID is not only relevant to the Department of Health, you've got Department of Education, you've got Ministry of Health, we've got Ministry of Social Services, you've got municipalities in general. I think all of us have to come together and say, within this community, what is the reality that we are faced with and how are we going to address it? Next slide. COVID also, it seemed like is no different as far as HIV is concerned. There is so much stigma that is associated with COVID. There are lessons that we can learn dealing with multiple partners when we were dealing with HIV, and COVID is not different. The stigma associated with the pandemic really challenged us in addressing and dealing with the pandemic adequately. Yesterday in South Africa, we celebrated Freedom Day. However, if you look at the conditions across the different regions in South Africa, the living of conditions of people do not reflect 26 years of democracy. The inequalities among society still reflects the era of apartheid, and it's just making things a little bit difficult. We also seeing a lot of classism amongst the poor, middle income and those that are of higher income, where those that are lower incomers are saying, this was never our disease. It's a disease that belongs to the rich. They travel abroad and bring us the disease. And unfortunately, as the ones that are trapped in these communities, we are then contracting this disease in one way or another. We know that most of the domestic workers may work for those affluent people that may have traveled abroad. And one thing that we have to think about when we are thinking about this is how transmission will look like in the community, because it's a little bit different than how the initial disease or pandemic went out. I would like us to take the picture on the left-hand side with a pinch of salt. I downloaded this from Twitter, but it was quite interesting for me because it just depicted stigma that may be associated with trying to trace contacts when you are dealing with people that are COVID positive. So I'm just going to try and read it, and I like the humor that goes with it, which is the part of coping that I said people are dealing with it. So it says, one girl from Cape Town in Gugulethu is found COVID-19 positive. So the family of the girl and her boyfriend are now quarantined. It's later it was found out that the girl has 3 boyfriends, so the 37 members of those 5 families are put into quarantine. But now wait, we come to know that the 2 of her boyfriends have 2 more girlfriends. Among those girlfriends, one has 2 more boyfriends. Among them, one is married. And when it ends, it says syllabus in mathematics called COVID-19 maths. I think this for me is quite interesting, because as we go rigorously in trying to address the pandemic, we will be screening, we will be doing testing. But as we are registering people, will people, particularly those that are going to test positive, will they give us accurate information around their contacts? Or because of stigma or whatever reason, we will have challenges in trying to trace as many contacts as we can. One of the other 2 modes that we've seen is around funerals, is around churches, where tracing of contacts becomes challenging in those particular environments, in people trying to understand how many people have been could have been affected as we are trying to determine their contracts. Next slide. So one of the key things that we have to think about as we are tackling misinformation, because what we've seen when COVID-19 really hit us, it was the amount of misinformation that circulated. And I think amongst all of us in this platform, perhaps we were able to deduce what's correct and what's incorrect. At some point in time, it was even difficult amongst healthcare professionals to be able to do that. Is it airborne? Is it not airborne? So how does this look like for an ordinary person in the community, particularly the people that we are saying we want them to change their behavior in order to prevent COVID-19? So instrumental to this is going to be the role of community health workers, is invaluable. I cannot stress this enough. They are going to be the key agents of change. One, because they are trusted in the community, they are known within the community, and they may be the key agents of change, even though there are risks associated with that, and that's something that we will discuss later. We've also seen community-based organization in South Sudan with branches in Cameroon, Kenya, Sudan, and Ethiopia, where they are helping to initiate #211 Check Collective. If you have time, kindly look at the work that they are doing. It is an amazing work. And I think what for me has been imperative in the work that they are doing is how young people are stepping up in order to try and address miscommunication using whatever platform that they deem necessary to be able to deal with the pandemic. And what is good about their work, it exposes false facts, disputed and unfounded remedies or cures that we know comes up, and any other information that is misleading the public. Therefore, COVID-19 has made it almost impossible for us to deal with issues. And I think their work is really trying to address issues around social distancing, issues around self-isolation, because it goes into details in terms of the work that they do and the measures and the various platforms that they are using in order to address communities in their context, in their languages, within the youth that is known in those communities, and they become the change agents in order to deal with the prevention. The next slide. The big question is going to be, how are we meaningfully going to engage our communities? There are good lessons that can be derived from the Ebola that struck us at some point in time. We know that community engagement was pivotal as a key strategy to interrupt the Ebola transmission. And how did they do it at that particular time? Using this practical community level measures that were explored in the field, and they were tailored for specific context of those communities, not assuming anything, but understanding what those communities required, using healthcare workers, using survey, anything that was possible to collect as much as information as possible with the communities that were affected. And community engagement needs to be strategic. You need to build leadership capacity within those communities. You've got traditional leaders, you've got health clinic committees that exist within those structures. So what we are picking up with COVID-19 is the amount of solidarity fund that comes with it. And that comes with corruption, that comes with abuse of funding that was meant for the vulnerable. And suddenly, if there's not enough leadership capacity built in those communities, you start seeing things happening. What was also interesting for me, it was one of the daughters of Nelson Mandela, just a day after President Cyril Ramaphosa had announced the billions that were going to be available. And she tweeted and said, 2 people have already approached me asking if I've got a non-governmental organization. Is this going to be, are we going to be immune as hospices to this type of corruption? That's going to be something that we have to think about, and it is possible. The other element that I really want us to think about, which is really breaking my heart in South Africa, is how everyone is living in poverty, and when food parcels are coming, we start discriminating against those that are not South Africans, those that do not hold a South African passport or South African ID. And that for me is, as palliative care professionals and advocates, we see no color, we see no ethnicity. Of course, we have to account for the resources that have been given to us, and undocumented foreigners becomes difficult to deal with. But does it really goes to an extreme of us not making sure that those people at the end of the day have eaten and they've got something? They are as much need that support as the South African citizen. And I think that's one of the things that, as much as we want to change behavior, one of the behaviors that we need to change as Africans is treating each other with respect, particularly in times of the pandemics that we are dealing with. The reality is that in the midst of COVID, there is still a need for people to visit hospitals daily, to visit NGOs, to visit hospices, for the other essential needs in terms of other chronic illnesses that they are dealing with. And the big question here is the previous one that I've asked, is that what are the infection control measures? Are they adequate to be able to support? And if we were to support that, how would that support looks like? And we have to start thinking, how does the normal looks like beyond COVID? The next slide. We've seen a number of community action groups across the African region coming up and you know, rallying behind COVID activities in one shape, form or another, whether it is in prevention, whether it is in management of the disease, or whether it is addressing issues of social distancing. And the question that I want us to start thinking about, where are hospices? Are we visible enough? Are we responsive? Are we flexible? And flexibility, how does it look like? The reality is we do not have governments that will come to hospices and say, this is how we want you to support us. Probably it may also require us to say, how are we going to repurpose ourselves to be able to address and start attracting the multitude of funding that we see that's been lying around, particularly for COVID. The next slide. What it is that we know about palliative care and what it is that we know that our patients will need at this particular point in time. How are we going to assure communities patients will not be abandoned in cases where intensive treatment for COVID is unsuccessful or invaluable? Provision of the best possible care. I think we know that the quality of care that is currently being received at different levels, be it primary health care, be it tertiary, be it in a district hospital, we always question the quality of care. And one of the things that we pride ourselves in palliative care is the quality of care that we provide to our patient. In an event that death is inevitable, how are we going to deal with it? Unfortunately, COVID is isolating people and people are dying alone, and how is palliative care going to play the role? Is it our responsibility to ensure that people feel confident that they will receive the palliative care that they so desperately need? That's something that we have to think about and ponder. The next slide. So the next slide, I've looked at the Africa CDC COVID-19 strategy. It's defined in 3 pillars, so the strategy is in 3 pillars. It's looking at how are we going to prevent transmission, how are we going to prevent deaths, how are we going to prevent social harm. And I looked at this and I thought, if you were to take the same analogy and move to the next slide and say, in this context of preventing the transmission, preventing the deaths, and preventing social harm, how would palliative care look like? The next slide. So what is the role of palliative care? I think there is an opportunity to change the mindset on hospices. It may be different in other countries, but there is some part of the community that deems and assumes that palliative care only looks at the end of life care. And we need to start reiterating that message that that's not the case. Producing protocols. One of the things that for me has been amazing to watch is how much, whether it's WHO, is countries having been able to change policy just like that in the manner at which the pandemic has come out. Protocols around infection controls, protocols around community screening, how that looks like, what is our value as palliative care in trying to put our footprint as far as palliative care is concerned. Redeployment of skilled community health workers into the communities. We know one of the things that we heavily invest in palliative care is education and training of skilled professionals. And one of the things that we are picking up right now is how primary health care is being challenged where that is possible. Rapid training to address additional palliative care needs that are associated with COVID-19. In terms of the second pillar, what are the things that we need to do in preventing death? We are good in managing pain and symptoms. That's something that we've done well. And we know that people are dealing with some kind of pain or another. There are a number of inpatient units across the globe that are still in operation in Africa. Some have shut down due to how expensive it is to run an inpatient unit. Is it time to start repurposing those inpatient units as self-quarantine sites? Is it time to start looking at, could we use those inpatient unit as an ICU, because what we're seeing in South Africa, we had 3 private hospitals that were shut down because a number of healthcare professionals tested positive. I think for me, this was the most alarming thing that can ever happen in a private hospital, where we are making an assumption that infection control measures are of the highest standards, and therefore you would not expect that 3 private hospitals will shut down due to infection control measures. And the question is, as palliative care, there's been so much that has been done around infection control, and how are we contributing to that? How are we going to manage comorbidities or any other condition for that matter? I think one of the things that's going to be the most difficult to deal with is how do we make sure that other healthcare program remains sustainable while we are dealing with COVID-19? Because if you go to the Ministry of Health, everyone is dealing with COVID. And we know that funding in Africa does not allow us to have dedicated healthcare professionals to deal with outbreaks. So ideally what has been happening in South Africa is that you've got one person that's dealing with outbreak, 1 or 2 people, and suddenly that support was not enough given the magnitude of COVID. And then in terms of the last pillar, which is preventing social harm, what are the things that we can do? We need to package simple, tailored messages that are relevant to the communities, because we are within those communities. We know what is required. What is the risk of COVID and the ways to self-protect? I think for people to start changing their behavior, they need to know what are the risks associated that are relevant to the context, and how can they self-protect themselves. Community cohesion. Unfortunately, COVID is really breaking that down. And unfortunately, we just are social beings and community cohesion. So how do we continue to manage community cohesion within the prescripts of COVID? Collaborating with other stakeholders to address social and economic conditions. I think as much as we are saying people should stay at home, people are hungry, people do not have food. There's some kind of loss of income, and people are fearing what would be the next. Next slide. So this slide is just information that was adapted from Jennifer Moore in the California State University. And for me, it's somehow detailed vividly how our role would be in palliative care. So while WHO is reporting the average death rate from COVID-19 is somewhere between 2% and 4%, the death rate among the elderly patient is estimated at 15 to 22%. Managing pain and symptoms and ensuring comfort in dying and supporting families is going to be critical, and that's what palliative care is known for. An acute infection may be what collapses the house of cards. I think I couldn't have said it better, because this is the reality that we are going to deal with, particularly with those that are living with life-limiting condition. A rapid assessment of patients' goals and alignment. One of the things that we know that we do well is patient care plan, where it's something that has been done, and currently it's nowhere near, and COVID requires us to do so. If resources are stretched and an elderly patient with end stage experiencing his 4th or 5th exacerbation may not be prioritized for ICU care, and instead will need palliative care. If ventilators and ICU beds are in short supply, hospitals will have to triage cases and communicate to patients and families an alternative path. But the question is, what is that alternative path? When we know that our healthcare system is in nowhere near able to deal with issues that are not related to COVID, and somehow COVID is just creating that extra burden. And again, the question is it possible to repurpose the inpatients unit? Is it possible to repurpose the current infrastructure that may look different in one African region to the other, and say what it is that we can do in this case? The next slide. Families and authorized proxies may be prohibited from visiting acutely ill, chronically ill patients in hospital, and that's something that frustrates people more than anything. And I think with the skills that's embedded within palliative care, this is something that we can do. Maintaining grace, helping patients and families to understand and decide and coordinate care, it is critical. Nurses and physicians and their colleagues may be overworked and at risk, and that peer support becomes critical. And we know that there are multiple peer support programs that currently exist just in the field of palliative care, whether here or overseas. Spiritual care and team support and guidance on self-care, it's going to be pivotal at this stage. The next slide. What's going to be our role as hospices in community screening and testing for COVID? There has been a huge undertake of mass screening in different parts in the region, and that's something that we want to look at to say, in terms of doing this huge screening, do we have the correct communication? Do we have some risk assessments that's been done? How are we engaging communities? How are we ensuring that there's provision of personal protective equipment for community health workers? We know that is the most vulnerable cadre, and that's going to be in the cold phase. Will we be able to facilitate the protection of community health workers against criminal elements during community screening and testing? That's something that we have to think about. They are in the front line, but who's going to think about their safety, and how is their safety going to be guaranteed? Addressing human rights issues. This has been one of the things that has been key in palliative care, where the rights of the ordinary community members are taken care of. And this should be no different when dealing with screening and COVID-19. Ensuring that household insecurity, household food insecurity, water and sanitation, and we are not saying as hospices, let's do this, but within the communities that we are in, there are stakeholders that we can collaborate with to make sure that when we are saying to this ordinary man or grandmother that you need safe water, that there is actually indeed safe and clean water in those communities. And what is the importance of the access to the accurate information that is within the languages of those communities? Next slide. I think more than ever, integration of palliative care into the healthcare system has never been more challenged. And I think in countries where there are some elements of this that are still missing, we are deeply challenged as far as palliative care is concerned. One of the things for me that was interesting that I pondered about when I was thinking about this presentation, it was the Declaration of Alma Ata on Primary Health Care that was endorsed in 1978. It expressed the need for urgent action by all governments, all health and development workers, and the world community to protect and promote the health of all people. I can't emphasize the health of all people, not those that belong to that particular country, but the health of all people. Globally, palliative care is now seen as an essential part of universal health coverage. And that's something that we need to take pride in as we are crafting ways to deal with COVID. The reality is that the pandemic is escalating rapidly across the globe, and the need of palliative care is paramount, as the burden of as the disease burden from both communicable and non-communicable diseases is increasing, and the number of new infections and new death is creeping in on a daily basis, and really highlights the critical need to protect our vulnerable populations from contracting the virus. I think one of the things that we've been challenged generally with COVID, but that presents an opportunity for everyone in palliative care, is that palliative care, it is a multidisciplinary discipline from the start of diagnosis up until at the point of death. And unfortunately, COVID, it's almost, you sick now, you severe, you die, or you recover. And it's that range of care that not all healthcare professionals have been used to in a speed at which COVID is challenging us with. So dealing with mental health and psychosocial consideration during COVID really presents an opportunity that we have to think about. People are worried about their loss of income. People are worried about isolation, but more than anything, I would like us to all, let's not forget the children. I think children and the elderly are going to be at the most risk, not only at the risk of the COVID, but the adjustment that we are asking people to do. Kids are not used to being isolated. They are not used to being these enclosed environments. They want to be out there with their friends. But I think the child that I want us not to forget as hospices, because I know some hospices are having range of services that are beyond clinical management, that may have an element of dealing with vulnerable orphans that are vulnerable. And what does it mean? Most of us, probably everyone that is on this platform, our kids are dealing with their school issues. We've got enough data. We are able to say what would be the next, and they may complete their grade this year. But how about the ordinary child that is in this picture? And this is saying I'm not against online teaching, but what about us? And these are the kinds of communities that hospices are embedded on. And the question should be, how do we address this? And how do we contribute to this? The next slide. Gender-based violence has been on an increase, not only in South Africa, but across the region. If you look at the latest UNFPA report that has been published on gender-based violence, it does indicate that it has risen exponentially, and people are advised or required to stay at home, and women and girls may not be able to leave any unsafe or violent situations. And these continues to be people that have been accessing care in hospitals, in hospices, or in primary healthcare settings that may find themselves in our doorsteps. Sexual and reproductive health is crucial during lockdown. Dense populations are drivers of the transmission. We know that our healthcare system is overloaded, and only will, in some cases, are providing limited set of services. In other cases, some of the primary healthcare facilities have been repurposed, either as a self-quarantine site or as a treatment site, depending on what the regulations are. So just regular checkups for women are going to be challenging. With schools closed again, let's think about our children. We are going to be challenged on on some other issues, particularly if you think about female genital mutilations, where children are under dire situation, and child marriages in the rise. bereavement has been instrumental in palliative care. And unfortunately, COVID is challenging this like never before. We know that when people are dying, there are rituals that are being performed around death that are important for any grief that will be healthy. And with the highly infectious nature of COVID-19, families are struggling to say goodbye to their loved ones in hospital or any other condition. And if you know the typical funeral in a village where people continue to share food in one dish, use one spoon to dish, how are we going to start changing that behavior? Respectfully so, in saying, you need to start now changing your behavior because COVID requires us to do so. With these funerals in isolation, we are guaranteed that we are going to deal with complicated grief. And as hospices, we know they are tailored existing trainings that are there that can just include COVID messages to be able to support people during their complicated grief so that people do not have to die and feel alone at this point in time. Thank you very much. I would like to thank APCA for providing me with this opportunity and sharing this with you. And as much as I was sharing the information, I'm also looking forward to hearing from other people, and I've been seeing questions coming up to say, how are other people dealing with this, and how can we as hospices do this together? I would like to end with Maya Angelou saying, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And unfortunately, COVID is challenging us like never before. Thank you very much, Emmanuel.
Thank you very much, Toby, for that very rich presentation. And we are very grateful for the presentation. We have a number of questions, which I think we can let you answer within. We have another 8 minutes. The first question came from Shelley, and it's about messaging. She said, thank you for this excellent presentation. Have there been any COVID prevention messages that you have found to work effectively within communities, considering the challenges that you've referenced?
Okay, can I take a number of questions and then respond, Emmanuel, if it's possible?
Yes.
Emmanuel?
The second one is from Alois. She's asked, Alois says, precisely elaborate more on how effective community strategic engagement will help to fight spread of COVID-19, given adverse social cultural differences that exist among our African communities. And then the third one from Marculine, it's really more of a comment where she says, thank you very much for the presentation. One of the recommendations is giving the right information in a language they understand. I think we should also find ways of countering fake information, because people get information from all over and are not sure what to trust. More so, we direct them to government directives, while most people don't trust their governments in the first place. So those are the three we have on the questions. And
okay.
Yeah, so maybe you can deal with those.
So yeah, maybe let me deal with the first initial questions. And I apologize for taking so much time and not having enough time for us to engage and discuss. So in terms of messages, what we've done in South Africa, and I think what has been really instrumental is government at a national level has set up a multi-sectoral committee that's dealing with COVID. And within those three arms that I've highlighted, prevention of transmission, prevention death and messaging, there are different committees that are dealing with this. So inputs were really gathered, and what was used and instrumental that I need to highlight is that using current structure that are already working in communities. So we've got South African National AIDS Council that's very prominent in South Africa, and that has similar structures at provincial level, at regional level, and that structure has been having multiple webinars, and we've been engaging communities through that structure and soliciting information. So we've got national COVID messages that are in about 6 different languages at this point. The aim is that eventually we'll have all 11 languages. And what we've seen is that this has been really effective. And one of the things that we've been doing, the question that's related, what is the communication, what is the community strategy? So we've been using, where possible, in donors, where possible, existing community structures for entry points. So if we've got screening, if we've got any information that we are going to share in a specific community, Department of Health will not necessarily be the face. The mayor in that community would be the face, because he already has existing structures. But like I indicated, unfortunately, this has its own downfalls, where Solidarity Fund, that's currently being managed by various agents, has somehow created some kind of corruption. So to a certain degree, you'll find yourself in conflict with communities because you are seen in existence with other structures, and therefore if something goes wrong, you are all being classified in that same community. And I'm more than happy to share what has been done to date in South Africa. There are so many protocols that have been developed, communication that has been developed. We're just updating the last community messaging that was just focused on COVID, and we were saying, how do we make sure that other programs are sustainable? HIV, chronic medication. One of the other things that has been really interesting and encouraging for me to see is how differentiated care has somehow taking a different shape in the midst of COVID. So initially in South Africa, for any patient to be decanted to receive their medication outside the healthcare facility, they needed to have 2 suppressed viral load. But because we are saying social distancing, limited movement because of lockdown, we were able to amend those and come up with memos that says, how do we make sure that during lockdown, people do not default to treatment? So as much as COVID is a pandemic, but it has also made us see that it is actually indeed feasible for us to change at the speed that is required, which initially we know how long it takes to change any kind of policy. So I think let's engage our communities using the existing structures, and let's acknowledge that it may be hospices and other role players, and we want to be seen participating in those forums.
Thank you very much, Toby. Just one more round of questions. We have from Dr. Paul Mbando from Tanzania. He is raising the issue of dealing with extended families and how that fits in isolation, staying at home, and life in slums. I think it's something you touched at the beginning of the presentations. And then he also raises the issue of African traditional herbs and remedies and how important they are in COVID-19. Then we have a comment from Afolabi. He says that comorbidities worsen the effect of COVID-19 on individuals. I'm of the opinion that more information should be provided at every point in time to lessen the burden of disease conditions. What do you think? And then Mark from Uganda put a general comment on stigma related to COVID-19 and how that needs to be handled, because he thinks that the kind of stigma generated may live with us even beyond COVID-19. So I think those are the last questions and comments. Over to you, Toby.
Thank you so much, Emmanuel. So the issue of extended families is a difficult one, particularly if you look at the socio-economic conditions in which people are living in, which is why it becomes extremely critical on how we use messaging. For example, let me use an example that's not related, and I'll try and address it. Some of the screening questions during screening and testing and mass screening was saying, have you traveled overseas in the last 2 weeks? And I was like asking myself, how do you come in an informal settlement and be asking people, have they traveled overseas in the last 2 weeks? And one of the community members was saying, I think you guys are almost, it feels like you are laughing at us. And I think some things are well intended in the beginning, but I think as you implement, you adjust the strategies that you are engaging in. So dealing with an extended relative, what is currently happening in South Africa, they are identifying multiple areas that can be used for self-quarantine and self-isolation. And one initiative that for me that has been interesting and involved in is working with the military. So the military, this is happening in the 3 regions. One region is KwaZulu-Natal, Free State, and Gauteng, where a parking lot in a military base is currently being repurposed for self-isolation and self-quarantine. So how we are going to start communicating to extended families that you will be taken away from your family, moved to this type of infrastructure. And part of what we've been working on is that while other people are thinking about infection control, other people are thinking to say what infrastructure is required, what equipment is required. Emphasis that we've been working on is what communication is going to be in place when we communicate with extended families that I'm taking a breadwinner and going to self-isolate a breadwinner. What does it mean to a child that will be left alone? What safety measures are in place? So unfortunately, COVID-19 almost says self-isolate, be on your own. But again, you're going to depend on your neighbor next door to look after your children when those things happen. And I think we have to acknowledge that as we go along, we do not have the answers. It's trial and error. But unfortunately, it's trial and error that may cause people's life, or they may alter people's behavior in adjusting them and making sure that they are able to address their needs. So there is no clear-cut answer in terms of how you deal with extended relatives, but is how we start looking at the resources that are available within that community. And I can share with hospices in South Africa, what we've done in South Africa is documenting by district to say, these are going to be the self-quarantine and self-isolation sites. Some are ready, some are not prepared, some do not have resources, some do not have equipment. And I think that's where I was asking a question as hospices to say, how do we repurpose ourselves in the midst of COVID? And I can assure you, government officials are running like headless chicken. I don't see any one of them coming to us as hospices and asking us what is our role. I see us taking the opportunity to say, this is what exists and this is how we think we can try and add value. Value add in terms of the skills that we have, value add in terms of the protocol that exists that can easily be integrated, value add in terms of providing healthcare professionals that can do training in management of COVID. And lastly, in terms of comorbidities, if this, I did not stress this enough, I know there's one slide where I'm emphasizing this point to say that's what palliative care is all about. We deal with a person in totality, not in terms of this particular condition. So I cannot overemphasize that.
Thank you very much, Toby. This has been a very educative session and very useful to all of us. We will share the slides with the people who have attended, with your permission. So attendees, please give us time to work with Toby to send you the slides.
Definitely, yeah.
Thank you. We want to thank everybody who has joined from, I've seen people from West Africa, from Southern Africa, from Eastern Africa, and North Africa, and some from outside Africa. We want to thank you very much for joining. Please keep in touch. Our next session, I think, will focus on how to raise resources at such a time, and that will be maybe in the next couple of weeks, but we'll alert you about that. Unless Frank has a comment. Frank, do you have any comment before we close?
No comment.
Okay. Thank you very much, everybody. Thank you very much, Toby. God bless you.
Thank you, everyone. Much appreciated. Thank you for the opportunity. Bye-bye.
Bye.